Welcome back, everybody. This is our fifth installment of our Bold and Brave series. So we're excited today. We're going to launch into the topics of palliative care and hospice and all topics and misconceptions and perceptions that surround that. So this would be a great conversation. Just a reminder kind of what this series is about. This series is really about kind of opening up the door to difficult, hard, but necessary conversations surrounding all topics related to disease progression and the end of life. We're doing this because it fulfills the mission of PINCT from day of diagnosis through the end of life. We're doing this because it's a missing resource, not only in Project PINCT's programming, but also in the community at large. So it's been great this far. We've got a lot more planned. Tonight's going to be a great conversation. And I think we'll just kind of launch into it. So we've got Dr. Teply and Kacie, and I'll let them do their own introductions. I'll do a brief introduction, and then we'll kind of just launch into it.
Okay, should I go first?
Thank you.
Okay. So where to start with this? I am from the Midwest and trained at UNMC for my medical school and did internal medicine training and then did primary care in Baltimore for 3 years. And toward the end of my internal medicine training, I realized that I gravitated toward patients who were dealing with cancer, both because the symptom management, you could be a little bit more creative with that. It wasn't quite as evidence and guideline driven. You could kind of think through things with the patient, partnering with them. And then when I was in Baltimore in primary care practice, when my patients got really sick, whether that was with a cancer that was incurable or something else, I didn't see them again as a primary care physician. And I was really drawn toward trying to be a support with them during those really difficult times in their life. And then as they transitioned to the end of life. So I went back and did a palliative medicine fellowship in the Baltimore area and then came back to Omaha in 2017. My practice at Nebraska Medicine is entirely outpatient. Half of that is in primary care still, and half of that is in outpatient palliative care.
I'm Kacie Flaherty. I am a breast cancer survivor. Was originally diagnosed as stage 2, and then after some further testing, we found some tumors in my liver that moved me from 2 to 4. You couldn't have had better timing because that was the year I was diagnosed was 2018. So you got here and just in time. I worked with Dr. Teply throughout my treatment, and hands down, she was my quality of life doc. Made it not as bad as it could have been. So
Great. And I'm Clay Hoberman. Similar to Dr. Teply, I'm a palliative hospice and palliative care physician. I started my medical life as a physical medicine and rehab doctor. And for lots of experiences and stories, I found myself in palliative care for very similar reasons. Also, can I call you Mel?
Yeah.
On camera?
Yes, please.
Okay.
Yeah.
So we'll go first names here.
Yeah.
That's I think makes the conversation easier. So. Found a gap in our healthcare system and really found that I was restricted in treating people the way I thought that we all ought to treat them, and palliative care provided that opportunity for me. So I've been practicing palliative care since 2008. I've done inpatient medicine at all the hospitals. I've done clinic in a couple of locations. The last 4 years I've been practicing full-time hospice. And we'll dig into what all of that really means and looks like as we go through the conversation. So I think, we're really fortunate to have Kacie here. Like we've tried to do with the prior talks, is bringing it to a real level. And Kacie's, your story is real. And we appreciate you coming on and sharing it with us. And I think that helps this conversation. I think it helps everybody watching at home understand this conversation a little bit better because we're speaking in a real experience rather than generalities and things like that. So I think maybe the best place to start is, as much as you're comfortable, just digging into your story and with an emphasis on really where where palliative care fits into that, and
Sure.
and then I think we'll kind of just go from there.
Sure. Yeah. Like I said, I was diagnosed stage 2, did some scans and found 3 tumors in my liver. 2 were over 4 centimeters, and another was this perfectly round little 1.5 centimeter mass. And I thought palliative care was for those who were dying. So at stage 4, I'm no longer curable. So, okay, let's do this. I'm signing up. And through that, oh gosh, how many times did you save me? I mean, when we convinced the doctors to let me fight and to let me do the tough treatment and to do the cryoablation and the high dose radiation to the liver tumors to get rid of them, and now we're going to fight the tumor that was in my breast, we wanted to be so aggressive because I didn't want to die. I wasn't ready for it. And yeah, I called you up, and every time something went wrong, and every time I thought that my oncologist wasn't listening, I would go down the hall and see you, and we would talk about how, I brought up this symptom. One of the symptoms I dealt with a lot was constipation, and the advice I was given was to drink a Miralax every half an hour until I had a movement, and that the first thought in my head when I heard that was, no, that's not happening. So it was a concern I brought to you, and you worked with me and gave me a couple of different medications that made it to where it wasn't such a problem for me. And that quality of life right there, I spent way less time in the bathroom. And we went through several things. I think with the neuropathy, you got me on gabapentin and got me so where I wasn't in so much pain. And honestly, I just felt heard. And sometimes that is the hardest thing when you're in an oncologist's office and they're attacking the cancer and they have this plan. Sometimes it feels like they forget that you're a human being. And so that was I'm really grateful to you for that, because I was heard. And like I said before, it was something that could have been so much worse than it was if I hadn't had you. So.
And that's huge to hear, because most of the time I'm going through my day saying, I don't know if this will work. I don't know if this will help. It's worth a try. And you just kind of tug along and do what you can. So it's really, it's incredibly meaningful for me to hear that it's making a difference. Because oftentimes those are relatively small things, but if it's the one thing that someone else didn't think of, then it's kind of filling in the gaps, exactly. as Clay was saying. Yeah.
And if this sounds a little ambiguous to people, I assure you we're going to circle back around and kind of unpack what all of this means, because I was just taking a few notes. What your brief synopsis of your story, you hit on some really significant points of what palliative care is and can do. And so there's some things I think that's worth talking about. We're going to kind of go initially into define what palliative care is, define what hospice is, how to view those differently yet very similar in a sense philosophically. There's a couple of things I wanted just to bring up. You, if I remember parts of your story, you're very commonly you have to go find palliative care. Palliative care doesn't find you. Right. And I remember that's part of your story is you learned about it and then searched it out.
Correct. It was complete serendipity how I learned about palliative care. I was on an airplane ride back from Atlanta and sat next to a doctor in palliative care who had given TED Talks on palliative care. And so it led to a very interesting conversation, and the nerd in me was very excited to speak to a scientist. And so, when I had the chance to hear what he had to say, the second I became stage 4, it was like, okay, I need to get palliative care. I mean, it took very little convincing for me to search it out. And outside of that, no, I don't think anyone mentioned it to me as far as you should consider getting, symptom management or anything like that. So
good. So that was one of the takeaways I had from yours, is that we are not yet culturally at a place where where palliative care is a routine recommended recognized, valuable part of your team. Certainly valuable, certainly recognized, but you have to make it happen lots of times.
Yeah.
And so that's part of why we're doing this whole series, is for people to have awareness of what that total conversation really looks like. So,
and I think it's what's interesting about you having been in practice since 2008 and me coming into this in 2017 is it does feel like there's more momentum on the medical side too, that part of my job is also training physicians to become palliative medicine doctors like myself and Clay, and also educating in the medical school, and also educating doctors who are going into oncology about that value, and there's still just lots of different dynamics that are there that sometimes there's a discomfort with bringing up palliative care even. And so I think that that's getting better from both ends. And this is so wonderful to have this conversation tonight.
Yeah, good. You brought up a couple of things that we're going to hit on, but quality of life. You're going to hear you've heard quality of life in every conversation we've had. You'll hear it a lot tonight, because that's essentially palliative care is the specialty that's focused on quality of life. And that comes in lots of different forms. We're symptom management and psychosocial support and all of the pieces that come with that. But the medical management, the specialty, I always say our specialty is symptom management, right? Oncologists are great at treating cancer, let me say. Treating symptoms is something they will all do because they're treating humans, and that's if somebody has an issue that's affecting their well-being, then people want to try to find a solution. However, I like to say let's let the oncologist focus on what they do, because that's hard work, and let palliative care doc or provider focus on what we do, which is symptom management, right? Your Miralax treatment, while not uncommon, is unfortunate, right? Because it's just it's not a sustainable existence, right? You can't do that. So we have lots of tricks up our sleeve. We use meds in different ways. We can make compounded creams. We can make liquids. We do all sorts of things a little bit differently, but again, those are bits and pieces. But the idea is that palliative care serves a very useful purpose in lots of things, and we're going to go through that. So I think maybe we'll start, so we don't get in front of ourselves. There was a question about what an appointment looks like, and whether it's with a team, and I think that's a question that we're going to define really what palliative care is first, and then we can dig into that a little bit. Either you can talk about your appointment from a personal standpoint. You could talk about your appointments. So why don't we just start kind of, and I'll throw it over to you, Mel, if you're okay with that.
Yeah.
What is palliative care?
Yeah, I'll take a half step back as a bridge. Oftentimes when I'm introducing myself to a patient, this is a lead into the appointment as well, is that I'll talk about that really from the cancer center standpoint, we're trying to give people the best of both worlds. Like the oncologist is focused on your cancer treatment, and I'm here as part of the team working with them, that we want to help people live as long as possible and feel as well as possible in that process. So I see palliative care as a extra layer of support for people who have serious illness. And so people can go back and forth on how they define serious illness. Particularly in the cancer center, there's a professional recommendation that anybody who has a stage 4 cancer, the oncology societies are saying we recommend palliative care be involved for those patients. That said, anyone else who is having any difficulty during their course, if that's symptoms, if that's some difficulty with just kind of the changes with it, the coping, the emotions that come up with it, sometimes the oncologist, like a person won't want to see a therapist, but like maybe they'll go see the palliative care specialist. So I see it as taking a really holistic view at the physical, emotional, spiritual issues that come up. And we do try to take a team-based approach to that in terms of how we're supporting the patients and families. And that can be, as I mentioned, at any stage of a person's illness. And so I don't know if you want to lean into hospice right now to kind of compare and contrast, or
I think let's unpack palliative care a little bit.
Sure.
And I would just say, from a bird's eye view definition, or explanation. Palliative care is first and foremost a philosophy, right? It's a different way to think. I'm sure Mel and I, neither of us would say it's a different way of thinking. It's a way that's not often thought and should be thought of more philosophically. To palliate really means to cloak, if you look at the root of the word. So that's where we get the symptom management piece. But palliative care is person-centered, symptom-focused, quality of life focused care for people who are have life-limiting, progressive, and or end-stage diseases, right? And that might mean years before the end of life, oftentimes. So maybe now is a good time. So hospice, I wish we had a diagram, but if you think of palliative care as an umbrella under which hospice is a piece, right? So all of hospice is palliative care. Not all palliative care is hospice, right? Hospice is the same philosophy that Mel's talking about and that we're talking about, but it's a distinct, defined medical benefit. And that comes with some things that you can't do, right? Like you can't pursue hospice, which is an acknowledgement that the disease has progressed to the point that we don't have a fix or a cure, and we're focusing solely on the quality of life. You can't ask to pursue that in most instances and pursue disease-focused treatment at the same time. It's a Medicare benefit. It's written into law. What Medicare does, most providers follow, right? Blue Cross and Medica and all of those providers. So it looks very similar whether you're a Medicare patient, Medicaid patient, or a private insurance. I think let's keep going on palliative care because the hospice piece is a much more narrow focused, and we'll circle back around to that. So.
To kind of bring that back, the big buckets that I put into that is helping with symptoms, helping with coping, what I call advanced care planning, which can include both like what people think of as advanced directives, but also what are the different medical interventions that might be possible, and then how that changes, and that can become very complicated. And so having those people, palliative care clinicians, are oftentimes like medical interpreters of like, we have the medical background, but then also like having an idea of like who the person is that I'm talking to, helping them navigate that uncertainty and the questions that they have. And then also, as we're talking about end of life, like for some people who we can get to that space talking about legacy work, like what are the things that are important to you about like how the people that love you remember you? And there's some really, like my friends always cry when I bring this up about people who have young kids, but like just these really incredibly powerful things that people can leave for the people that love them. And so that's one of the things that I enjoyed most about my work, but it's one of the hardest things for people to do as well.
Yeah.
So there was a question on the team approach, right? And so in hospice, that team is defined. It's regulated, at least the core members of what that team has to look like. Palliative care is just, not to minimize it, but it is a medical specialty by definition. So nobody requires cardiology to come with a team. Nobody requires dermatology to have particular components. You have to have training, but other than that, it's not a defined entity, right? So, what kind of team are you working with in clinic, or what kind of team, Kacie, have you experienced going through the clinic?
Oh gosh, our first appointment, I think you came in with a resident and my family, and sorry, I think that's my phone. It's going off. You came in, and one of the best things was, you just asked like, what's important to you, and I didn't realize how much you had written down until I had met with another doctor, and they were like, I hear you make a great cheesecake. I was like, what? She goes, oh yeah, Dr. Teply wrote it in the notes. Okay, like you heard me, and you wrote it down, and it really went from talking to a doctor to a friend. So as much as, is there a team? Not per se, but I put you on my team. of the team of the doctors that were taking care of me. So
To kind of answer that question from the healthcare system perspective, every healthcare system is going to have different needs in terms of what palliative care looks like. So the hospital that I practiced in Baltimore, it was a physician and a social worker. Here at Nebraska Medicine, we have an inpatient team, but in the clinic, it's myself, a nurse practitioner, and then we have a case manager, and we work very closely with the social workers and the counselors. And so I know that it's in Hastings, I think. They have a nurse practitioner that's in clinic. So every healthcare system is going to look just a little bit different in terms of what that team structure is for palliative care.
And I think in an ideal world, okay, I'll get to that. That's a good question. I think in an ideal world, maybe I'll just ask you if you could build a team, right?
Mm-hmm.
Money was no restriction. What types of providers or people would you have on that team to really provide a cohesive service?
All of them.
Yeah. Right. Social workers.
Yeah.
Chaplains.
Yep. A therapist, a child life specialist, a financial counselor,
Yep.
a nurse case manager, advanced practice providers, a physician. Honestly, having a physical therapist and occupational therapist that have that lens that they're applying. I pick every medical specialty, I would bring them into my team. And this is where you can kind of get into like palliative medicine is kind of meta medicine, that healthcare systems have kind of gotten a little bit detracted from, like, our intention is always to care for patients as best as possible, but sometimes we prioritize saving lives over like the holistic care of patients.
Sure.
And so everybody is walking in with that intention, but then there's just so many competing expectations that sometimes the priority falls a little bit lower as best as we want to do it that way.
Yep. And I've done lots of home visits in my past, and it's an interesting contrast to get a referral from a primary care provider or oncology, who unfortunately get 7, 10, 12 minutes in a visit, right?
Mm-hmm.
You can't get to know somebody in that kind of time period. And so I read their notes and it sounds like everything's going great. And I go do a home visit because I think from a palliative standpoint, you really need to, the better you can find, learn about that person's existence in their environment, how they function, helps us treat better. So you do a home visit and it's, it's not what the doc and clinic thinks is happening, right? Mm-hmm. I mean, people are organizing their meds in garbage bags and dumping them out every morning on the table and trying to, there are very easy, simple things to do to clarify a plan of care, to simplify a plan of care. And that's another thing that palliative does is thinks, so many times, take 2 of these 4 times a day. That pill comes in a double that strength, so we could just take 1 of those, and right there you just cut your pills in half, right? And it's not hard things to think about. They're just things that lots of providers aren't focused on. So again, it all comes back, I think, just to the approach, the philosophy is just a little bit different. And what I was getting at is there are lots of psychosocial determinants to health and poor health and good health. And so social workers are great resources and counselors are great resources. And there's a lot of community resources that people aren't aware of. And so when we talk about a holistic team, we really want to be able to try to find, a way to approach that person from mind, body, and spirit in a holistic manner. It's holistic in a sense of viewing humans from head to toe, right, as whole beings.
I'm curious, back to the question of the appointment. I don't know if you remember, like, if you had any expectations going in, or you were nervous about what to expect, and then how the appointment, the first time we met, flowed for you.
I had no clue. I mean, I had seen the TED Talk and the things that he had said about focusing on what mattered most to them. Mm-hmm. And yeah, I remember you took a whole page of notes. Uh-huh. And it was just, we're talking about the things that mattered. We were talking about the things that hurt, the things that were uncomfortable. about whether I was feeling heard, how the process of treatment was going. And I mean, you would bounce, well, we can do something for that. I remember when I told you I couldn't taste anything, and that was really sad. And you were like, oh, well, we have this antipsychotic. And I was like, oh, maybe not that one. And so it was, we kind of got to do it together. And I never really worried about the why with you, because it felt more like a team approach. So yeah, I had no clue what I was coming in for. But when I talk to people now, fellow survivors, it's my quality of life doc. Go talk to them, go ask them for help. And if you feel like your oncologist isn't listening, go talk to the palliative care doc. They will listen. And if they need to, they'll step in and talk to your oncologist, so that, at least somebody on their level is saying, hey, we need to either break this down for more, or we need to actually listen to them, or take the time to explain the things. And that's, it's huge. More than just cancer, right?
Absolutely. Yeah.
So there's a question about receiving chemo now and have developed a new symptom.
And
do I go to palliative care or oncology first? We're talking about for the managing the symptom.
And I can walk back just to say what my general approach is, because I do have kind of a flow of what to expect with the clinic encounter. So, oh my gosh, I'm having like minor PTSD from COVID, when we could only have one person in clinic with us. Like the patient could only bring in one person. I think now it's back to usual. But any family members or friends are encouraged. I've had people be on the phone. I've had people be on Zoom. I've had people be on FaceTime on the phone. That is totally welcome from my perspective. And oftentimes I'll talk about how I see palliative care, or ask people if they have preconceptions of palliative care, and discuss that I'm here to help with symptoms. I'm here to help with the things around the cancer. And then also, one of my big questions is, what are the things that are most important to you? And how do we keep that on everybody's minds going forward? And sometimes that has to be a reminder to the person who is most closely connected to the patient, about trying to help them with realistic expectations. And then also, of course, the medical teams. And so I spend a lot of time talking about symptoms. It depends on what's going on for the person. So I have spent 45 minutes talking about constipation and diarrhea with people. And then sometimes that's not the bigger issue for people. I really like to get to know who that inner circle is for people. So who are their close family members? Who are the people they depend on and trust? What are the things that bring them joy? So I think cheesecake was there from that question. And then trying to figure out how I can personalize how we talk about things when it gets harder down the road. And so I oftentimes ask people, how much do you want to know about what's going on and what to expect? Some people do not want any information. And so that's really helpful for me to know that, so that I can try to figure out who to personalize that with. A lot of people understandably go back and forth. Like, they kind of maybe want to know some things, and then other times they really don't want to know. And then a lot of people are like, I'm an open book. I want to know whatever. And so that really helps me modulate how much information and how plainly I'm speaking, versus how much I need to how much I need to be more patient with building trust before we go to those more difficult places. And then I'll do a check-in about how things are going with the cancer treatment. And then from there, it depends. If someone's doing great and they're doing okay, I might say, I'll just check in with you in a couple months. If we've done a lot of different changes, or have made a lot of recommendations around symptoms, then I'm probably going to be checking in with them once a month. And so it's really variable depending on the person. And so sometimes it can drive people crazy that I speak in generalities, but I really do see this as highly personalized care. It's complicated, and it always depends on that person. And so I am going to try to tailor it to whatever is going on for who I'm meeting with.
Right, and we've talked about that in prior talks, that the majority of medicine is very protocol driven. Mm-hmm. Right? You get pneumonia, I get pneumonia. On paper, our treatment looks the same, right? There isn't a lot of individualized, nor probably should there be at that point, because it's driven by the science and the data. Mm-hmm. When we get to the point in life, either from an age standpoint or a disease standpoint, we need to really individualize that, because that plan of care, based on your needs and your wishes and your goals, looks different. And so, right, that's a great point. I think palliative care is excellent at really individualizing that approach to care and and the plan that's put together moving forward. To get back to that question, I would ask you, Kacie, if you had a new symptom, something that Mel doesn't know about, hasn't yet treated, so let's say it's a Tuesday, you wake up, something new has happened.
Yeah.
Who do you pick up the phone and call?
I think the answer is both.
Okay.
I mean, I hate to say it to be vague like that, but yeah, from my chemotherapy, I was meeting with my oncologist before every appointment. So I could talk to him about what was happening and what I was feeling. And I think we met every month. And sometimes we met during the infusion. You'd come down to me and we'd talk about what was happening. And if something felt off or felt like, I'm telling my oncologist all the things that are happening because they're asking as well, how are your feet and fingers feeling? And are you experiencing this? And you answer their questions. But just like the Miralax thing, the answer I got was not, to me, helpful.
Didn't work for you.
No, my first thought was, that's not going to happen. So now what? And so that was where I brought in Dr. Teply and said, okay, I have this issue. This is what I was told to do. I need something else. And, oh gosh, I mean, we gave Senna and then I got Linzess, and that was a lifesaver on more than one occasion. It was, I did what I needed to do to get the help I needed, if that makes sense. So if my oncologist wasn't giving me what I felt I needed or what was a good enough answer, then I came to my palliative care doc. And there are some things where when I'm helping others or attempting to help others, I would just straight tell them, that's a symptom, take it to your palliative care doc, like go talk to them.
Right. Not in the sense that you're cutting out the oncologist.
Right. No, I'm fully expecting them to talk to each other without me, like to kind of close that triangle into a full communication. All of the scans and things that they do, I can't tell you how many times they're like, okay, well, we have to meet with the team and then we'll let you know. And don't you hate that when it's just like, tell me what I'm doing now. I want to know now what the plan is. But when I brought her on the team, that I expected her to be in on those conversations too. This is what this scan said. This is what we're going to do next. This is how she's feeling about it. She's getting tired of the chemo. That's why we ended up doing 15 instead of 16, was because I didn't want to do it anymore, and that was a really rough period of my life, easily the worst couple of weeks of my life. But, I had support and I had people fighting for what I wanted in addition to what the cancer needed. And that was important. So you do what you need to do to make whatever you need to happen. I mean, and if that's ask why until you get someone to get out the crayons and draw you the reason why, keep asking why.
Good.
And I'm also struck, you are such a remarkable person with, I hate that people have to advocate in the way that you have, because on top of everything that a person's going through with cancer treatment, anything that is like an extra step in your day is not my intention. And I'm somewhat aware that you are a person who is like, that answer's not good enough for me. I'm going to go find someone else who will get it for me.
Yes.
And I'm also mindful that there are other people who might not feel comfortable doing that.
Yeah.
And so that's where I especially hope that, and the oncologist will, at Nebraska Medicine, my relationship with the oncologist is just as important to me as my relationship with my patients. Because they will say, I'm really struggling with how to take care of this patient's pain. I need them to come over and see you. I need your help with this. And then there's a number of patients who will come to us saying I'm ready to see palliative care. I want you to help me with this. So in my mind, it's this triangle that flows in either direction. So if someone's having a symptom from chemotherapy, they started chemo and they're not feeling great, generally speaking, my advice is to contact the oncologist. That said, if it's been pain that I've been working on with them and there's something that's coming up or they're more constipated, then I would expect someone to call me. That said, that can get totally confusing. And so most of the time I will just say, just call one of us and I can triage. I know when someone is calling in with symptoms that make me concerned that maybe the cancer has spread to their brain, or maybe the cancer is affecting their spinal cord, and this is something where I need the oncologist to be aware of. Like a person might call me with that symptom, and I'll say, I have to talk to your oncologist, and we're going to talk as a team and get back to you. And then similarly, there's other times where a patient may be talking to their oncologist about their itching or their hot flashes, and the oncologist says, like, why don't you wait and talk to palliative care about that? So I think it's a flow that my biggest thing is for people to understand that we are a team that works together, and that no matter what the question is, like, we'll try to find the best answer we can.
You guys have both brought up a point that I think helps round out what palliative care does. We've talked a lot about the symptom management, the medical pharmacological piece to that. Palliative care, the other role we play is conversation, right? And part of that is translation of all this medical speak, is kind of gathering the chart, trying to interpret all of this, and then presenting it in a real, concise, understandable human conversation. And so one of the things I think we pride ourselves on in palliative care is communication, and not just communication with between consumer and doctor, but really from palliative care to oncology. Who's talking to cardiology? Who's talking to oncology? So palliative care, in the best that we can do in a broken communicative healthcare system, is I just try not to perpetuate a lot of the problems in our healthcare system that come down to poor communication. And so, I think the answer to that question of who to call, it probably depends on what your team looks like and how you've been functioning. I would say, I don't know a palliative provider that would ever be upset that you called with an issue. And if that palliative provider has the answer and is the right person, there's your answer. If they're not, we're going to tell you, let us call this person, or you need to call this person, or let's head down this path. So the communication piece, I think, is very important. So that's a fairly ambiguous answer, but it really depends, I think, on who your team is at that point. You would not have called palliative care if you didn't know, if you hadn't had a relationship, I would assume, right? When a symptom came up.
Yeah.
And now, if you're feeling poor, I suspect that Mel is probably the first phone call you make. And not that anybody's trying to step on toes of oncology or bypass oncology. I have not met a lot of oncologists that would turn down the opportunity for somebody else to manage the symptoms associated with the treatment of the disease. So that's a good question. Do you have to be stage 4 to get palliative care? So I think Mel and I both have lots to say about that. Let me answer that. I'll give that to you for part of it, but let me answer that. Palliative care, while this is specific to cancer and more specifically breast cancer, palliative care is not only applicable in cancer situations, right? I mean, any chronic progressive disease that leads to significant disability, symptoms, and eventually the end of life. So those are neurological diseases like ALS and strokes, and those are lung diseases like COPD and heart diseases. And so to answer that, no, you don't even have to have cancer to get involved with palliative care, but certainly stage 4 is not a requirement. There is no requirement. The requirement is you have a need for palliative care, right? And I'll let you kind of take the reins on that one from the clinic standpoint, because you're getting people probably in all aspects of their disease trajectory.
Yeah, the other way that I could read that question is, if a person had a stage 2 cancer, could they see palliative care? And I think I'm going to attribute this to you, that you put this nicely, that if someone's going through cancer treatment and they've got a lot of pain and symptoms, and it's a curable cancer, that of course, palliative care can help with that symptom management. That stuff's like really fun for me.
Yeah, I would agree.
Like it's like, oh my gosh, I get your pain better. Like your taste is doing better with the weird antipsychotic medicine that you were like, what? Those are like huge wins for me. That is so much fun to do. And then the hope is, and the expectation usually is, that people start to feel better as they finish out their cancer treatment. And then I kind of fade into the background. So like that, I don't continue to see them indefinitely if the symptoms are controlled and the cancer is doing okay. So it can go in that regard too. Remind me the question that you were asking about the palliative care clinic in terms of.
Just as far as like who, that in line with stage 4 or stage whatever.
Oh, yeah.
But who are you receiving?
Yeah.
When are they coming to you?
Yeah. There, again, I think it's going to look a little bit different depending on the healthcare system that a person's being seen in. At Nebraska Medicine, we are still only in the cancer center for outpatient palliative care. And when I first started, there was both trying to build the reputation for palliative care when seeing patients and families of the benefits of that, so that there is the word of mouth, which Kacie has been wonderful at spreading, and also building that trust with the oncologist for them to be able to say, this is worthwhile and this is something that I'm going to refer patients and families to. And so initially I just told the oncologist, anybody who is having symptoms that you're having trouble controlling, or any people that you perceive that they are having trouble coping with how things are going, or where they're perhaps at the end of their life and you're talking about hospice, but the person is not ready for that, then they would refer over to me. As we were able to build more trust and I was able to help people with whatever issues were coming up, then the oncologist started to refer earlier and earlier and earlier. And so for lung cancer in particular for stage 4 lung cancer, the oncologists, we have, I'd say like a working understanding that they refer the patient after the first visit. Like that's a standard process. Someone comes in, they're diagnosed with a stage 4 lung cancer. The oncologist or the case manager is going to say, we recommend palliative care for all of our patients with stage 4 lung cancer. We really want you to see them for an appointment. And if people don't want to see us, like it's not a requirement, they're not forced to come see us, or if they do see us and they're like, yeah, I don't think this is a right fit for me, that's fine. And we can see them later if that makes sense. In GI cancers, we have a similar understanding. In breast cancer, what's so challenging about breast cancer is that breast cancer is not one type of cancer. There's so many different variations of how things can go for people. And so we don't have that same type of standard agreement, but I have had people who have stage 4 breast cancers that are very near the end of their life. I have people who have had very significant pain. That's a great question of, do you have to be referred? So that actually leads into exactly what I was just going to say. And then I have a number of people, interestingly enough, maybe this is the word of mouth, of the various different types of cancer. I noticed that more people with breast cancer tend to come find us or ask their oncologist for a referral compared to other cancers. So technically speaking, by like the system standpoint, in terms of getting an appointment, there needs to be a referral that is done. That said, I don't know any oncologist at Nebraska Medicine that if you called them up and said, I'd like to see palliative care, they would place the referral readily. Like there wouldn't be anything where they would say, well, no, you don't qualify or anything like that. So like technically speaking, someone needs to help make the appointment, but patients are welcome and encouraged to bring that up if they would be interested in seeing a palliative care specialist.
And multiple times in your conversation you were just having, without directly bringing it up, you've talked about or around a misperception of palliative care. And that's really that people, and I will say the healthcare community, right, most other providers fall into this misperception as well, is that people believe that palliative care is only for the end of life. And so when I'm in the hospital and somebody would refer to us, or in the clinic, I hear from PCPs, no, we're not ready for palliative care. And I just think, gosh, that's an opportunity for us to educate on what that really means, because I can tell that's a misunderstanding, right? That's like if you have a heart, I keep using cardiology, I'm not picking on them, but if you have a heart problem, you go to a cardiologist. If you have a symptom problem with a chronic life-limiting progressive disease, you should be going to palliative care.
I have a great example. was like one of those bless your heart moments. I had a patient that was going to see dermatology, and there was a question that we were talking to each other, and they go, "Oh, you're palliative." So the patient's on palliative care. And I was like, I don't know what that means. Like, all the palliative care means is that you've got an extra person on your team.
Right.
Like, it is all the same usual care that has been happening, all of the same medical interventions, specialists, anything like that. It is still all of those things. And you have this extra person who is asking if you like cheesecake. So.
Right.
I would like to say that in my research while I was Googling the docs and the TED Talks and everything that I was digging into it, the best example I found was palliative care is for anyone who is suffering.
Right.
If there's something going on, talk to a palliative care doc. And yeah, I mean, who wouldn't want a team putting their brilliant minds together to give you the best treatment with the least amount of symptoms or the best symptom management for what you need to get through? I mean, if you're hurting, if you're suffering in any way, like, call them.
Yeah, and I would say, so whether you're in the hospital and somebody recommends a palliative consult, or you're in the outpatient setting and somebody recommends getting palliative care involved, there isn't a secret message behind that. That's not a cryptic way to communicate within the team. It's somebody's appropriate recognition that's a specialty that you should have involved in your care, and for all the reasons that we've been talking about, I think. But palliative care is still in its infancy. It was not a true board certifiable medical specialty until 2004, maybe 6, somewhere in there, early 2000s. There've been people doing it for decades, but it wasn't officially recognized as a medical specialty, and it is now, right? And so you can see that there's steam building along the way, and so all of this is just building awareness and understanding that there is help out there that we've not been utilizing, and it's unfortunate, but it's just trying to break down that stigma. I think we have a long way to go, but we're a lot farther than we were 20 years ago. So sometimes that is a sticking point, right? And I hear it, and oncologists are unfortunately have sometimes that sentiment as well, is that we're not ready for palliative care. They view it. Okay. Well, yep.
Great question and
yeah,
great lead in.
Yeah. So that question was, is it a lead into hospice, right? Am I reading that right? Is it a lead into hospice, or is there a handoff? Absolutely, right? So again, so hospice is now a defined entity. It comes with a whole different team, and that hospice, I guess that's a good time to start to dig into the definition. So hospice is the same philosophy we're talking about, is the same medical approach we're talking about, but it is kind of the completion of that shift towards an acceptance and understanding that we're in a position with a disease trajectory that we don't have any other good, appropriate, disease-focused options, right? And we've had some talks. The last 4 talks really have dug into that. There's often a point for people to say, what I'm doing over here isn't providing the benefit any longer that it used to, or that I hoped it would, and I would like to focus on comfort, quality of life. And that doesn't mean bedbound status. That means if you want to go play golf, you should go play golf instead of going and sitting in the doctor's office for 2 hours waiting for a 10-minute visit that isn't going to change the course of things. So hospice is people and medicine and equipment that are all focused on trying to achieve the goals that you set out, right? That you guys have talked about. With excellent symptom management, with holistic care. So hospice is a team of the people are physician, nurses, social workers, chaplains, volunteers, regulated, Medicare regulated, that hospice has a volunteer program, bath aides. Some agencies have massage therapy, some have music therapy, some have pet therapy. But those are the cores that we talked about that are there, and those people come to you. If home is at home, that's great. If home is in a nursing facility, we come there. If home is at the shelter down by the airport, the team comes there. So that hospice team is designed to meet people where they're at. They all visit. They don't all visit at once. They're not showing up in a van at the same time. You might see the nurse twice a week. You might see the social worker once a month. You might see the chaplain. It's all designed on around what your needs are. And those people come to you and they bring any equipment that you might need, and they think about things that you don't need now, but you might need down the road. Those people, that team kind of wraps their arms around you and is there to kind of handhold through this end of life process, making sure that, that you're treated with respect and care and dignity through this end of life process. So it is absolutely a continuation. In an ideal world, from a hospice doc's ideal world, you have palliative care involved upstream, and that it is a gentle, slow kind of, I don't want to say slow, it's a gentle, non-abrupt handoff to hospice, right? I mean, it should just be a natural progression of healthcare. Instead, currently, lots of times it's this very abrupt, there's nothing left to do. Now it's time for hospice. And that's not the right way to treat people. It feels bad. Patients tell me they feel like it's an abandonment.
Yeah.
Right. And it's somebody didn't have a conversation until on Tuesday you walked in and they say, hospice is the right thing for you. And that's hard.
There's two things that I generally highlight. I mentioned earlier that in the palliative care clinic, when I'm working with that oncologist, we're trying to help have that person fight for as much time as possible, and also fighting for the time to be as good as possible. And then realistically, what happens is at some point, the cancer is going to continue to change. And so at some point, we don't have any control over the time. And so what we have control over is what time looks like. And so with that, hospice is the best support that we have of helping people through that time. The other thing that I'll sometimes say that seems to connect with people is that oftentimes the person who's dealing with the cancer, it's this really challenging thing about accepting more help and having more people come around. So oftentimes I say, you don't need any more help. You have your family and your friends that are here. They need another support layer. And so I'll sometimes say to people, I'm like, this isn't really for you. This is kind of for your family and your loved ones, because they need someone to acknowledge that they're doing right by you. There's so many times where the person who's doing a lot of the caregiving is worried, am I dosing this medicine right? Or I'm seeing some changes and I'm not sure if this is okay or if this is normal or whatever that is. And that's where that team coming to the home and looking at how you're doing and how your family is doing. And something that I love is I describe, usually that hospice nurse is going to come in here and say, we're going to do this, 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 and this. And then they're going to say, is that okay by you? And it's yeah, that's so helpful. Yeah. So I find hospice to be incredibly important. I think in terms of the transition, with the healthcare system operating the way it does and hospice going to the home and me being in clinic, oftentimes when we're at that point of that handoff of the teams, I tend to tell people that hospice is the new first go-to, and at the same time we are absolutely still there in the background. So I know that there have been some patients where there's been particular questions that have come up that you and I coordinate on care. Sure. And several of the nurses at St. Croix will contact me and we'll work together to make sure that transition is hopefully as seamless as possible.
Absolutely. I've left out a really important definition of hospice. Is everything we've been talking about is great. Hospice, the one defining piece of that is that you really, by definition, it needs to be, it's a service that we engage for people that have a anticipated prognosis of 6 months or less of life. I didn't talk about that piece. It's a really hard piece, right? Because prognosticating is not a hard science. It's trying to piece together somebody's story and figure out where they are in that process. And it's almost never a hard stop, right? We have patients who live much longer than we think, and that's great. We celebrate that. But we are charged with trying to take the information available to us and prognosticate 6 months or less. If you called me and said, I think hospice is the right, and we talked, and I'd say, what do you think the prognosis is? If you said in a realistic clinical impression, 18 months, I can't, and I know you wouldn't do that because I know how it works, but just as an example, palliative, there is no time definition for palliative care, right?
Correct.
When it's appropriate, it's appropriate. Hospice, because it is a distinct entity, there is a time component to that, and it's asking us to try to find patients that we believe are in the last 6 months of life. That being said, we use it very poorly in the sense that we're using it too little and too late, right? I mean, if we can talk Medicare data, 48% of us in the Omaha community are utilizing hospice at the end of life. And while Medicare, again, I speak to Medicare knowing that that's not a lot of the Project Pink population, but Medicare says it's the only Medicare resource that we underutilize in healthcare, right? Lots of overutilization in healthcare. Medicare says, here's 6 months of this great team that's going to come to you. They're going to treat you as a whole person. And we're using about 14 days on average. So I think personally, like we would both love to see that utilization improve. You're now got great exposure to palliative care. You have become a champion for it.
Anyone that wants to listen to me.
Yeah.
Yeah.
This is so Kacie. I'm just going to read it out loud so that everybody's aware. But the question is for Kacie. It says, do you only go if you get new meds or symptoms? Otherwise, you aren't using palliative care, or are there check-ins?
Well, right now, I'm lucky enough to say that I've been just over 2.5 years, no evidence of disease. So I think it's been a little over 1.5 years since I've seen you. But she's in my back pocket. Like, I know that if I need anything, all I've got to do is reach out. And so no, it's not just for new meds. It's not for new symptoms. I mean, I think when I've had issues with things during the pandemic, I was unable to sleep. Oh gosh, I was sleeping maybe 2 or 3 hours a night, and I reached out to you for some help. And you were able to get me some things that were able to help me sleep. And that made a world of difference. It got me back on a normal person's schedule, and helped with the depression that was coming from just having been by myself for so long. So I don't want to say like, I only use you when I need you, but like, that's exactly what I do, you know, like.
And part of that is that you're doing great. And so I wouldn't ask to see you once a month when you're doing great, just to have I wouldn't like want to force an appointment on you every month when you're doing okay. Had you been a little bit more timid, then I do tend to kind of mama bear hover on people. So once I have met someone, as long as they will keep letting me check in on them, I do. And so at the end of each visit, generally I'm asking, can I see you again in whatever time period makes the most sense? So even if you had been more timid, let me back up. I know you will reach out to me if there's something that's going on. If I didn't have that sense of you, I probably would be saying, let's check in every 6 months and see how you're doing. And then if there's things that, I had this happen with a patient the other day, was that I hadn't seen them for a year and there was a refill. And so my nurse said, why don't you just check in with them? And so I did. And it was like, they were not feeling great. And so it was like, I am so glad that my nurse suggested this because I'm going to see him again in another month. And there were a lot of adjustments that we made. And so it ramps up and it ramps down depending on how a person's doing. And different people may have a different practice, but I definitely like helicopter mama bear unless someone's like, you know what, I don't think this is a good fit. I don't know that we need to see each other again, which happens a couple times, and that's okay.
Yeah.
I would say when I was doing clinic, I saw people frequently in the beginning because I'm getting to know their story, right? You can do a 90-minute visit, but you still probably haven't scratched the surface of who that person is. So, and then as you're getting symptoms, if you're starting management of symptoms, I like to see people, sometimes I was seeing people once a week because we were making rapid changes. And then once things, like you were saying, once the water is kind of calm and we get things, then it's every 2 weeks, then it's once a month, then it's every 3 months, and then it's kind of based on what the needs are. So,
Well, and once your chemotherapy appointments stop, you kind of stop seeing your oncologist for a little bit because, okay, this is what we've done. You'll get your scans, then we'll talk about it, but you'll go see surgery next. And you were right there with me during that time, because the after effects of the chemo were still happening. And, it was really important to continue seeing you because it was, the effects aren't done. I mean, yeah, the exhaustion that came afterwards was huge for me. And it feels a little bit bad now to be like, I still have a handicap permit because we had decided that if the cancer doesn't go away, then the handicap permit shouldn't either, right?
Pull that C card out
but,
when you can.
Yeah,
Absolutely.
But I mean, I don't use it if I don't have to. But when I have the bad days, even now, when the exhaustion from the pain or the Ibrance that I take gets to me, yeah, every once in a while I will still use it. And every time I do, I think of you and how grateful I am for you being willing to do that for me. And I've got to say, and this is one of, I don't know, maybe it doesn't really pertain so well, but you were the only doctor appointment I went to where I didn't have to take my top off, So it's one of those things where, you joke about like, oh, I gotta go get felt up again. There's another doctor's appointment. And like, this was one where it didn't. And that was super nice.
I'll offer hugs at most visits.
Yeah,
Yeah.
right,
Request to
right.
take your top
Yeah,
off.
yeah.
I think what you're describe. Obviously, I have a different impression, but I view palliative care docs are a different kind of doctors.
Yeah.
They view your visits different. They view you different. I mean, I've not been a consumer but I don't want to put words in your mouth. But I think what you're saying is it's a different experience. You have a comfort
entirely.
level that you may not with some of your other doctors.
Yeah.
There was a question earlier that I wanted to ask. You're a strong advocate for yourself. How did tell me what was the conversation with your oncologist? Or maybe you didn't involve your oncologist in the conversation of getting palliative care
I
involved.
didn't. No. I reached out to the gentleman who I sat next to on the airplane and said, hey, because we had exchanged numbers just on a science background. And when I got the diagnosis, just reached out and said, hey, I listened to your talk and you sold me. He was from Des Moines, moved to Oklahoma City, and it was like, do you know anybody in the area that I could go see? It turns out I'm going to need him. And he wrote back, let me do some research. And I'd say within a day or two, I had Dr. Teply's email address and said, you need to go see her. This is who will take care of you. And if they don't, you let me know. And it was okay. And, from there, it was just telling my oncologist, my palliative care doc said this and she got me this, so I'm good. Or she's in on it. I want you to, make sure that she's in on the conversations and the things that will direct the treatment from here on out. So no, I went on my own.
Good.
But
And I ask that not because right, we've talked about the stigmas that are associated with palliative care, and lots of providers in the healthcare community still kind of carry forth that stigma. And so I'm looking for a way to give people assurances that one, you can involve palliative care. You're not going to upset an oncologist or a primary care if you ask about it or ask for a referral. And I want your take on that too, since you're working inside more of the acute care system.
I look at it as some healthcare providers do still get confused between palliative care and hospice, and so they'll say, like, when we say palliative care, they think that a person is talking about hospice. I think about it more as the same way that physicians and healthcare providers are reluctant to bring up discussions around prognosis and end of life, that's a sensitive conversation, that we can't read a person's mind and we don't want to upset them and we don't want someone to be angry with us. And so then generally the choice is to just not bring it up. And so then the conversations don't happen, and it's out of politeness. It's because like they're nervous about upsetting the person. And bringing up palliative care can be a similar thing, because that awareness that everyone's going to think that palliative care means that we're not doing cancer treatments anymore. We're talking about end of life. And so honestly, I think my perception of most healthcare providers' reaction when a patient or family requests palliative care is they're like, oh yeah, I think that's a great idea. Let's get them on board.
And I would say when I first started practicing in Omaha, there if I was in the hospital and somebody recommended palliative care, there was a lot of kickback from other providers. No, we're not ready. It meant something to them that it really wasn't intended to mean. I think over time, I hope that we've seen that break down a little bit.
Definitely in oncology.
Yeah.
Like at Nebraska Medicine and oncology for sure. And my understanding is that practices across the state are they've contacted us saying, how do we set up a palliative care program in our cancer center? So that everyone sees the need. There still are absolutely areas not to, like, it's the way that the programs are set up and the training is set up. A lot of transplant, like bone marrow transplant is like a whole other ballgame, solid organ transplant, heart surgeries. I think that's really kind of like I think we've addressed the lowest hanging fruit. I think that's the highest hanging fruit, that there's still more trust that needs to be built there.
Yeah. But I bring it up because I don't want people to, you're not going to, just like we've talked about when Cynthia was kind of going through her story, there is a fear of letting people down, and from a patient standpoint.
Mm-hmm.
And that includes, your support, your loved ones, but that also includes your docs, right? I mean, we had lots of questions and comments about, not wanting to let down their oncologist. I understand that. From my experience, I can't name an oncologist that is going to be up. They might not agree in the beginning, right? But the more we do, the more they understand it. We're not counteracting what they're doing. It's not counterproductive. It's a synergistic approach that we're both there for the same purpose. But I just want to give people the comfort that if it's the right thing for you, you can either ask for a referral or you can search it out. But I would just encourage people not to pursue something. Don't avoid pursuing something for fear of upsetting your doc. I understand it. It's a common thought process, but I'm trying to help. Right? I mean, your story is great. I mean, you were doing it. You found something. It was right for you. You had a gap in your care, and you went and pursued it. And then you told your oncologist, right? Mm-hmm. I mean, it wasn't asking for permission. It was, hey, I've done this. Yeah. Work together.
Yeah. Speaking of a brave conversation, that's a brave conversation for a patient to have with their doctor.
Right. So that's a great question. So this question about if you've been my doc and it's time for hospice, does that mean that you aren't my doc anymore? So I'll just answer that from the hospice perspective, and then I'll let Mel, you can answer from the ambulatory perspective. But you have to have a primary doctor on hospice. You have to have a primary doctor of record. And lots of times that's the hospice medical director. We serve that role. Lots of times it's the patient's primary care provider or palliative care provider. Very rarely is it an oncologist. So what happens is you come on to hospice and we will ask you, who would you like your primary care doctor to be? And they'll say Dr. So-and-so. And so then we make the phone call to Dr. So-and-so and say, hey, hospice is happening. Your patient would like you to stay primary. They can accept that role. They can say, you know what, it's not my wheelhouse. I'm more comfortable with the hospice medical director. Just keep me posted, keep me informed. And so to answer that question, you can keep your doctor if your doctor agrees to serve that role. Is that a fair way to say that? Is that what you see from the clinic side of things?
Yeah, I think from the kind of in the more acute care setting in the clinic, in the hospital, it goes all ways in terms of I've had patients where I've served as the primary attending while they're in hospice care. At the same time, when a person is in hospice and I am helping with those things. Oftentimes orders are being faxed to me, and I worry that it's not always the most efficient way to care for people. So sometimes I can get to that fax that day, but it might be 2 or 3 days before I'm back in the clinic where that fax went to. Faxes are the devil. That's like another story for another day. So I generally do try to encourage people to utilize that hospice team as the first go-to, although I'm always willing to serve as that backup. And then there are people where they're nervous about that transition, and so I'm more than willing to serve in that role so that they understand that I'm still very much a part of that team.
Yeah, and I would say from a hospice med director standpoint, when there's a primary care of record, that's the person that is the main point of contact for medical management. But the nurses typically will call the hospice med director and say, here's a story. Yeah. Let's get recommendations, because it makes the PCP's life easier if the nurse can call and say, here's what we're recommending. The doc will say, yes, no, do this instead. But again, trying to simplify life and make that communication piece as cohesive as possible. I would also say what I found in Omaha, in the smaller communities, it tends, what I find is that the primary care doctors want to stay as the primary care doctor on hospice. In Omaha, it's more the trend is to relinquish to the hospice med director, because we all know each other, and it's a fairly small palliative community, and so we all communicate, and that works out really well. This one's for you, Mel. It says, when is the ideal time to consider the move to hospice, and what are the things to consider in making that move?
The conversation that I tend to have with people is that, generally speaking, in most cases, it's either of two things. One is that the cancer is changing to the point that cancer-directed therapies, we just don't have other good cancer treatments against the cancer. The cancer is continuing to grow. Some people, truly, there is nothing else that the oncologist can think of. Generally speaking, in breast cancer, what's more complex about it is that if you ask the oncologist, isn't there anything else you can do? They'll say, well, there's this and there's this and there's this. But the reality is, for where that person is, what their body is doing, how tired they are, how much time they're spending in bed, it doesn't make sense to do any further cancer treatments. There's actually a risk in some cases where doing further cancer treatment can shorten life expectancy because of side effects and complications. And there's also the concern that, and my line in the sand is this: more than half the day, less than half the day. That if a person is spending more than half the day resting or lying in bed, then there's a higher chance that cancer-directed treatment, they're not going to feel good with it. And so as I give that question to people, we don't have control over time. So then what we do have control over is what time looks like. So how do we try to spend that time? What's most important to you about that? And that is where physicians will have disagreement, because there's lots of uncertainty in that. And a person who has an oncology background, they have, number one, seen more patients that they've tried that cancer treatment in that scenario. But also their toolkit is to give more cancer treatment. Right. And so if you say, isn't there anything else you can do? My answer is going to be, I wish things were different. I hate that we don't have other tools. Whereas the oncologist doesn't necessarily have that communication piece. And so they're going to say, well, we could try this.
There's always a study. Yeah, there's always stuff that...
And it's always out of a good intention. Sure. They're trying to be helpful with it. And the truly honest answer, the hard truth answer, is that for that person, generally speaking, if their body's in a place where, again, that distinction of more than half the day, less than half the day, it really doesn't make sense to keep doing cancer treatments. I have some people that they are very clear in their preferences that they do not want to do further cancer treatments, or they've done a certain number and it does not make sense for them. So based on how their body's doing, the oncologist might say, well, this is very reasonable for you to do this, and I do think that it would help you live longer and feel better. And this is where some people will come to me and they'll kind of feel like, am I crazy? And it's like, no, you're not crazy. If that's your preference, if you're clear in that value, and as best as I can prognosticate, like I think time is probably measured in months or less, then that's also a time when we'll transition to hospice. So it's either the cancer's changing, we don't have other good cancer treatment options, or the person is coming to me and saying like, this doesn't make sense to me anymore. I want to be at home. I want to focus on my comfort. And then I'm saying, well, then hospice makes sense as the best support. There's other more like nuanced, complicated situations within there. But those are like the big things that I tend to see.
That's a good question too. But really what that last question was really what it's getting at is prognostication, right? And it's the hardest thing we do. But we do have some tools, right? We don't need to get into all the scales that we use, but there's PPS scores and KPS scores and ECOGs, and we look at that stuff that gives us some insight into where somebody's at in this process. We take scans into account. We take, I say the best predictor of the future is the recent past. So if you've seen a fairly significant decline over the last 3 months, it's a good starting point to maybe start to move that same speed of decline and trajectory looking forward 3 months. I mean, it's a hard piece to do. What I would say is one of the misconceptions, there's nothing that palliative care nor hospice does or would ever do that speeds up a natural course. There's no hastening of death. There's no
and that's been well validated in multiple studies. Right. And there's actually some instances in which people live a couple months longer.
Right. There was a study that came out in probably 2012 with lung cancer that showed that people with lung cancer who were receiving palliative care not only live better quality lives, but live longer. And we saw the referrals like really start to come in from that. So prognosticating is really, really difficult. But what I would say is there isn't anything that's speeding up a natural course. Hospice and palliative care really doesn't have anything to provide or that's going to slow down a natural course. It's really there to support you at whatever your natural course looks like. You're leading us, and we're there to follow along and make sure that that's experienced with respect and dignity and comfort and in the manner that you want it to be done. So. Yeah, let's talk. So this first one says, do I have to go to a bigger hospital for palliative care if I'm in rural Nebraska? A decade ago, I would say absolutely. You might have a better grasp on what's happening west of here than...
You actually use the phrase get palliative. There is a website called getpalliativecare.org that is a pretty good listing of palliative care providers that across the country, and then it tries to list if they're inpatient or outpatient. So that's probably the first place that I would go to see if there's providers in your local area. And then I think there probably still are limited resources across the state of Nebraska, particularly in the outpatient setting, and that's also the case for Omaha. Yep. That said, I think that it is going to become dramatically better over the next couple years, and with telehealth, that has also been a huge game changer. Yep. So, Nebraska Medicine, I'm gonna mess this up of which practice it is. I think it's in North Platte that we have a relationship that I've seen patients on telehealth in North Platte. So it's a little weird that I've never met them in person, but I'd rather have us have met each other in some way than not. And I know that Nebraska Medicine is trying to build out partnerships with Greater Nebraska for both oncologic care, but those practices are saying, are you going to offer palliative care services as part of that? So that's part of the planning that we're doing. Yep. Do you need a referral for telehealth? So for us at Nebraska Medicine, we are only seeing patients that have a Nebraska Medicine oncologist. And that's in part because that that triad of that relationship, it's really important for me to have direct access to that oncologist and the patient. My best guess would be trying to talk to your oncologist as possible and see what options they think might be available for Greater Nebraska.
It's a great question, and it hits on the lack of palliative care. When I started in palliative care, the majority of large hospitals had a program, and I wish I was armed with the current data, but it's like something now 80% of hospitals over 200 beds have a palliative care program, and 60% of the. So the point is, the smaller the hospital, the less likely there's a palliative service, but that's changing yearly. Hospitals are recognizing the value and bringing that on board. You're more likely to find palliative care, at least in Nebraska, in a hospital than in an outpatient clinic setting. I mean, we'll talk about that a little bit at the end. That's true in Omaha. And if we don't have great clinic resources in Omaha, it's unfortunately we don't have great outpatient resources as you get farther west and more rural. There's a question about opiates, narcotics, the new laws. Obviously, we're kind of in the midst of an opiate epidemic, which unfortunately with the pandemic has lost a little bit of its news cycle. It's still happening. So this question is it easier for a hospice to manage versus palliative provider as far as the legal logistics of practicing?
I'm curious about your answer first to that.
Oh, you want me to answer first?
Yeah.
Is it easier? I have not found it to be difficult in either side. I think we all have a responsibility to be good stewards of those molecules that we put into the community. And so, it's never been difficult for me either way. I practice a little bit different in the hospice world than the palliative world. I'm a little more liberal. I'm looser with the orders. I think we all have an unspoken understanding that there's maybe a bit of a pass for us in the palliative hospice world. There's nothing stated by law or regulation that that's true necessarily. Let me hear how you answer that, and then I think we'll have a back and forth a little bit.
Yeah, I don't want to get too far off topic. I think in part you're going to see different generations of approaches depending on when a person trained in medicine. That I was trained right at the start of when attending started to say, don't prescribe opioids, like after the 90s where pain became the additional vital sign. And so then it was like...
Right, when I was in med school, pain was the fifth vital sign.
Yeah.
Treat it, and then...
And so I still feel comfortable prescribing opioids even when a person doesn't have cancer in very specific particular situations where you'll find a lot of people who will say, I don't prescribe opioids as a primary care practice. In terms of working in the palliative care clinic and trying to get people, first I want to step back that I always try to use other non-opioid modalities for pain anyway. Like that's always part of my practices. Yep. What else can I try to use for this pain? Because people don't love the side effects with opioids. But that said, there have been some things on the administrative back end that have been more frustrating. So for instance, if a person has more than a 7-day supply, it requires a prior authorization. And I have noticed this regardless of a person having a cancer diagnosis or not, which it was my understanding that didn't matter. And so like, I still prescribe that. It doesn't deter me from prescribing it. It's more that when I am first starting someone on opioids and it's very clear that they're going to need a month's supply instead of a 7-day supply, there's going to be a couple days where we have to do a prior authorization. And so it's just going to delay that a little bit, which is incredibly frustrating on my end. But like overall, we're going to smooth out the waters. Like it still doesn't change what I'm doing for people. And then there are more quantity limits that insurance is putting on things. So this is getting like...
But that's really, that's a payer source specific rather than a regulatory
Sure.
practice
Yeah.
component, right?
But I never have a fear of how much I'm prescribing for someone. Like I have never had to say I'm worried about the licensing regulatory bodies coming in saying that I'm prescribing inappropriately.
No, I think
Take away my
for all of
license.
us, if we're practicing appropriate good medicine, and most importantly, we're documenting the justification behind our thought process. I have not had a regulatory issue practicing. We do pain pumps at home on hospice. We do oral meds. We do liquid meds. You can do rectal meds. You can do creams that have pain meds in them. We all have to participate in the state. I've just lost.
The PDM.
Yeah, the provider. There's a provider database. They look at what we prescribe. You get a report once a month of here's how you compare to your peers. But again, in the palliative world, we don't have a ton of peers. There's 7 of us, right? 7 or 8 of us. So that last question about opiates was an interesting question, but I have not found that it's affected my practice.
The 2 other things I would say, just while we're on the topic of pain, is most of the time, people always worry about pain and how much pain they're going to have. Most of the time, I can get people's pain under pretty good control. And generally speaking, if I can't do that, then I'm asking an interventional pain specialist
Sure.
for the pain pump, like an intrathecal pain pump. And just along with the concern about opioids, I think buprenorphine is a medication that people are going to start hearing more and more about, that is a response to that those opioid regulations about trying to minimize risk of unintentional overdose.
Yep.
So this is my plug to, like, if you start hearing that word, that is something I think physicians will start prescribing more for pain slowly over time.
And I would say, they those meds like palliative care come with a stigma, and they are dangerous meds and they can be scary, but they're excellent tools.
Mm-hmm.
They've been around for thousands of years. They serve a purpose. They're great tools. Are they ideal medicines? No, they have side effects. They have profiles that make them hazardous, but if you use them safely and appropriately, they're excellent tools. And like you said earlier, one prong to your multi-prong approach to pain control, right? Anti-inflammatories and steroids and maybe therapy and a TENS unit, and all of those things you can put into the same pile. So when we talked about starting hospice, we looked at what palliative care is and who's on the team. We covered that. I think we covered hospice effectively. If we haven't covered any of these things, if you guys have burning questions, please submit them. We talked about misconceptions. We talked about a typical appointment for you. We've talked a little bit about treatments and medications that are involved in palliative care. That's kind of a wide topic, and we could really get into the weeds on that. So if people have questions about different things that we do or don't do, or how we might address a certain symptom, we'd be happy to take that. And then I think I have a list of questions here that people submitted. I think we probably covered most of these. So there's some specific questions about pain and anxiety and panic attacks, and how you treat those and how you manage those. I'd be interested to hear from your perspective when those symptoms have become issues. What your approach is, right? I mean, it's not always grab the pill and take the pill.
Oh no, gosh, I take enough of them.
Right.
It's little things, but it's asking your docs what I can do. I mean, sometimes massages are a really great way to get some stress out. Unfortunately for me, I can't, because I have permanently broken ribs from the high dose radiation, and so I can't get a massage. But I can do acupuncture. I can do deep breathing exercises, meditation, yoga. All of those things are actually really good for just centering yourself and bringing your mind back to your breath and kind of just soaking in the moment.
Yep.
That's really good. Well, for the anxiety, I guess I could say. Sometimes for the pain, there's only so many deep breaths you can take. And then you do have to do something. But, stretching, yoga, all those things, they're all... I mean, Pink has done a lot to bring up alternative healthcare methods for us, chiropractic care, all of those things that help. And I've used almost all of them. So
Good, right? And
Yeah.
I think that's really how you manage symptoms really well is you come at it from lots of angles, right?
Mhm.
So if you're going to treat pain, opiates are great tools. Steroids are great tools. TENS units are great tools. Lidocaine is a great tool. And if you can stack a bunch of these things together, you can use less of each of them and probably get a better cumulative approach. But biofeedback, yoga, meditation, acupuncture, I think is hugely underutilized. Um, they're all great tools. And I think that part of it is you got to find what works for you.
Yeah.
Because that's different for everybody. I don't know if there's other resources that you might employ.
I have no further comments.
Okay.
You answered that well.
This has been a great conversation. Thanks both of you for joining us. Thanks for sharing your story. It's always an honor for us to partake in that, and we recognize that's very personal and private, and so I think the opportunity that you take to share that is really helping lots of people, and it breaks down some of that fear and concern that's associated with these topics that we're going through. So thanks for being a part of that.
No problem. And if anybody wants to reach out to me on their own for questions or just to chat, I'd be happy to talk with them as well, just to share what I've got.
And I think to that, we have been developing a tool and resource kit kind of in relation to all of these talks. And I don't know, they probably won't be, they'll be broken down by topic, but we're going to find, we've got books, we've got some websites, we've got some organizations that would be useful to have in your back pocket. And so we're building that. We'll share the info and that'll be emailed out in the next month. Do you have in closing, Mel, like a good resource that you might send people just to learn more about what we're talking about?
Probably get palliativecare.org, which I think is an easy thing to remember. I think that's a great starting point.
Good. And then we have some books that we've talked about. We'll put that on the resource list as well. And I would encourage anybody that has a resource that they found very useful, let us know, and we'll put that on the list and share that with the wider audience too. So this conversation is being recorded, obviously, and it'll be on the website shortly. The prior conversations that we have are all up and ready to go on the website. We would encourage you guys, if you haven't participated in those, to continue watching those. And this is kind of a living program, so we're adjusting and adapting as we can based on the feedback that we get. So next month is going to be on advanced directives and the planning with living wills and power of attorneys and all of those things. So that should be a great topic. Please feel free to submit your questions when you register, and have a great month. We'll see you in April.